start the recording. So thank you so much, everyone, for joining us. I think probably we'll get additional people joining as we progress. But we're really excited to kick off the first SMRA webinar. This one focused on intracranial vessel wall MR. I'm Mahmoud Mosabasha, a neuroradiologist from the University of North Carolina, and we have an excellent slate of speakers, as well as my co-moderator.
My name is Chin from Johns Hopkins University. Nice to see
Can
everyone
everyone
here.
hear me? I lost the audio.
Yes, we can hear you, Bahagya. So our first speaker is Dr. Bahagya Sanananja, an assistant professor at Emory University in neuroradiology. And she's going to be talking to us about basic principles and current techniques of intracranial vessel wall MRI. Thank you, Bahagya, and can you hear us?
Hello everyone, my name is Bahagya Sanananja. I'm an assistant professor of radiology at Emory University School of Medicine. Firstly, I would like to thank SMRA for this opportunity. Today, I will be talking about the basic principles and current technique of intracranial vessel wall MRI. The talk is mostly tailored for beginners in vessel wall imaging. Intracranial vessel wall imaging is a technique which enables direct visualization of the vessel wall. Although black blood imaging was described in the early 90s, it is since past 5 to 10 years there has been significant increase in its clinical application for the evaluation of intracranial vessels. Currently, there is considerable technical variability due to continued imaging optimization. In this talk, I would be discussing about the basic principles of vessel wall imaging sequences, add-on blood and CSF suppression pulses, spatial resolution requirements, different tissue weightings that are available, and a comparison of 2D versus 3D acquisition, and finally, imaging acceleration techniques. Common pulse sequences for intracranial vascular evaluation include 3D or 2D fast or turbospinnacle sequences, which are the black blood techniques. Luminal imaging is always a part of the evaluation with pre-contrast time of flight MRA and most of the time contrast enhanced MRA. 3D T1 weighted fast or turbospinnacle with variable refocusing flip angle pulse sequence is the most commonly used vessel wall imaging technique currently. Flow suppression is primarily based on two mechanisms: gradient moment-induced intravoxel defacing and stimulated echo-induced intravoxel defacing. Sequences have significantly improved case-based sampling efficiency compared to the standard turbospinnacle due to its longer echo train length and shorter echo spacing. However, longer echo train length results in more T2 weighting and an overall decrease in the SNR and CNR because the later echoes tends to be weaker. So a variable flip angle refocusing pulses are used that compensates for T2 decay. Depending on vendor, it's called Space on Siemens, Vista on Philips, and Cube on GE. My apologies, the video is not working on this one. There are several physiologic or pathologic states and technical factors that can affect adequate blood suppression. Most importantly, the flow velocity. Lower the velocity, difficult is the suppression. The blood flow is a vessel is laminar, meaning the velocity tends to be slowest adjacent to the vessel wall, but the suppression can be inadequate and may mimic vessel wall enhancement. In some pathologic states, like high-grade stenosis, flow velocity can be decreased proximal or distal to the stenosis. Same thing applies to aneurysm, where slow flow within the aneurysmal sac can mimic aneurysm wall enhancement. The venous flow velocity tends to be on the lower side compared to arteries, and there may not be adequate separation like the example on the left-hand side. An additional consideration is orientation of these vessels. The vessels which are oriented along the frequency encoding direction tends to have a better suppression. On the right-hand side in figure A, there is apparent enhancement of the vessel or artery when the acquisition plane was axial, and this enhancement disappeared when the acquisition plane was changed to coronal in figure B. The image in figure B is reformatted so that both images are presented similarly. To overcome some of these limitations of incomplete blood suppression, a number of blood and CSF suppression modules have been developed and tested. An example is double inversion recovery. Here, the initial 180-degree inversion pulse inverts the entire volume of the tissue. This is followed by a slice selective inversion pulse, which restores signal to the slice via imaging. And then this is followed by a standard Spinnaker sequence, which begins after the blood in that volume has reached its null point, and inversion time is set to null any blood that may flow into the slice. Major advantages are it's a commercially available pulse, and it has negligible effect on the image contrast. Major disadvantages, it's not easily adaptable with a 3D sequence. Blood suppression is tough after contrast injection because T1 of the blood changes, and it is sensitive to rate of flow replenishment. On the right-hand side is an example of double inversion recovery suppression pulse compared to flow saturation in cervical vessels. MSTE uses 3 non-selective RF pulses and symmetric gradients. The gradient pair introduces phase dispersion among the moving spins, but the stationary spins are fully refocused and then restored. Advantages, it's a 3D suppression technique, it's flow independent and can suppress blood flow in every direction. It can suppress turbulent flow and also slow flow. The major disadvantage is it results in T2 signal decay and the signal reduction in the range of around 20 to 40%, which significantly limits its use for intracranial vessel wall imaging, even on a 3T magnet. Plus, it's sensitive to eddy current effects and magnetic field non-uniformity. MSD does a great job in carotid imaging. On the right-hand side is an example of MSD, which is figure B, compared to DIR in cervical vessels. Dante pre-pulse uses a series of low flip angle non-selective pulses interleaved with gradients. It creates a spoiling effect and the moving spins cannot establish a steady state. Advantages are it can suppress arterial flow, it can suppress venous flow, and also the CSF. It results in only mild decrease in SNR in the range of around 10%. A few disadvantages so far, like suppression is less effective when the flow is less than 0.1 centimeter per second, and there is a slight increase in the scan time. On the right side is an example of post-contrast T1 space compared to post-contrast Dante T1 space. You can see there is improved arterial and venous suppression on the Dante space compared to the T1 space. And you can also notice the images on Dante space are slightly grainier. We recently published this study in AJNR where we compared the standard T1 space with the Dante space or Dante Kaipi space. That's the flow suppressed and accelerated space. I will talk about the acceleration techniques in a little bit. We compared multiple qualitative and quantitative metrics as listed below. And our results showed Dante space performed better on all qualitative metrics except for motion. For the quantitative metrics, there was no statistically significant differences between the two acquisition types. There was a small increase in scan time of 7% with Dante space. Again, when we compared T1 space with with the dantic hyperspace, again, we found dantic hyperspace actually performed better on all qualitative metrics except for SNR. On the quantitative side, the T1 space performed better, but overall there was 37% decrease in the acquisition time with the dantic hyperspace. So one really needs to balance the clinical needs and workflow versus need for higher SNR when using these techniques, but improved blood suppression and reduced motion with dantic hype may offset the SNR limitation to some extent. Few additional pulses that's been described for CSF suppression. On the left is an example of T1 space compared to IR space. As you can see, there was improved CSF suppression on image B and better depiction of focal wall thickening of right MCA as pointed with the arrow. On the right-hand side is an example of ADE post-pulse showing improved CSF suppression. ADE can be incorporated into both T1 or PD techniques without much prolongation of acquisition time or significant signal drop. Both 2D and 3D acquisitions have their own unique advantages. The 2D techniques are more adaptable with increased motion resistance, have slightly improved blood suppression, while 3D techniques overall have increased reproducibility and accuracy, improved through-plane resolution, overall improved coverage, and allows for multi-planal reformatting. Although individual 2D sequences have relatively shorter acquisition time, when you compare the overall scan time, 3D technique still ends up saving time for us. Most places now perform 3D technique routinely, and 2D can be used as a problem-solving tool or when you know the lesion you're following up, like an aneurysm follow-up, etc. Although 1.5T can be used, most places now have shifted for 3T or higher magnet strength for intracranial vessel wall imaging. Wall thickness of intracranial arteries ranges anywhere from 0.2 to 0.7 millimeter, which is smaller than the MR voxel dimension that is currently achievable. But these arteries generate detectable signal, and by suppressing blood in CSF, it is possible to visualize them. Plus, any vessel wall pathologies typically results in wall thickening, which makes it more conspicuous. The ASMR vessel wall imaging study group has suggested a voxel size of 0.4 to 0.7 millimeter isotropic resolution for 3D imaging, and for 2D, 2 by 0.4 by 0.4 millimeter, which gives a good balance between spatial resolution and SNR. On the right side is an example of different spatial resolution and partial volume averaging effect. Figure B, which is acquired with a 0.4 millimeter isotropic resolution, shows improved delineation of the lumen at the site of mid-vessel stenosis when compared to figure A, which is acquired at 0.5 millimeter. These are some examples of different tissue weightings that can be used. Most places use pre and post-contrast T1 weighted images due to time constraint and clinical setting. Proton density images have higher SNR compared to T1 weighted images, but the enhancement may be difficult to appreciate. And T2 weighted images have unique advantages in certain situations like atherosclerotic plaque, where you can see the juxtaluminal T2 hyperintensity, as in this example. A major drawback of these techniques are longer acquisition time. Longer the acquisition time means more chances of motion degradation, plus it adversely affects the clinical workflow. So there are several acceleration techniques that's been developed and tested. Traditional parallel imaging techniques like grabber or SENS comes with significant limitations, like loss of SNR by square root of acceleration factor and also noise amplification. Compressed SENS is a combination of SENS and compressed sensing. Here, there is non-linear iterative reconstruction of sparsely undersampled case-based data. Advantages are it significantly reduces the scan time by approximately 1/3 and is also available as a product sequence with some vendors. The disadvantages, it can cause blurring and a global ringing-like artifact, and because these 3D sequences inherently have a low sparsity, only a certain acceleration rates can be achieved before we lose the balance of SNR and image quality. This is an example where acceleration factors of CS and grappa are matched. The image on the left is the standard T1 space, middle one is the CS space, and the right is a grappa accelerated space. One can see the CS space has a comparable image quality to standard space, but high grappa factor significantly reduces the SNR and results in poor image quality. CAIP is another acceleration technique in which the case space sampling is done in a way that decreases the aliasing artifacts. These are some examples of grappa-like case space sampling. The red dots are acquired data, and the white dots are to be tested. In the the left side image, you can see the acceleration is performed along a single direction, which results in a lot of noise. The middle image is slightly a better strategy where the acceleration is split between two dimensions. Compared to these two, in CAIP, there is sampling in phase encoding direction, but also there is phase shift of data in the middle column. This phase offset reduces the aliasing and shifts the aliasing artifacts to the corner of the image, thus reducing the G factor, and there is also less signal loss and superior image quality. In this example, from left to right, we have sagittal pre-contrast dantic CAIP space, standard post-contrast T1 space, and a dantic CAIP space with post-contrast. You can notice the difference in the acquisition time of these three sequences, and there are multiple enhancing foci along the cortical surface on the post-contrast T1 space as pointed with these arrows, which disappear on the dantic CAIP space. These enhancing foci represent non-suppression of blood signal and small cortical veins. Wave CAIP is another acceleration technique. It's a three-dimensional CAIP where the image acceleration rate of up to 11 times has been described, with some preliminary studies showing acquisition time to be as low as 3.5 minutes. These images show comparison of different acceleration techniques with their acquisition time and image quality. The image on the right-hand side is the standard acquisition. To summarize, accurate interpretation of vessel wall imaging requires imaging optimization. One needs to strategize for an optimal SNR, contrast, and spatial resolution that can be achievable in an acceptable acquisition time. With continued technical optimization, clinical utility is bound to increase in the future. Thank you all for your attention. I'm now going to stop my screen share.
Okay, thank you, Bahaya, for the great talk about the technical aspect of intracranial vessel wall MRA. And we will have a Q&A section at the end of after all four talks. So now we move on to the next talk by Dr. Hadiya Baradaran from University of Utah on clinical value of intracranial vessel wall MRA.
Hi, good afternoon. I'm going to be talking about the clinical indications for using intracranial vessel wall imaging. And I have no relevant disclosures. So just to dive right in, we're just going to briefly cover about what is intracranial vessel wall imaging. And in its most basic sense, it's imaging that uses high resolution to evaluate the vessel wall rather than just for luminal narrowing. And traditionally, we have relied on DSA, CTA, MRA to evaluate the degree of narrowing in the intracranial vessels, but with vessel wall MR, we can actually image the wall and get a better sense of what's happening outside the lumen and to evaluate potential causes of vessel narrowing or wall inflammation. So vessel wall has been used more frequently in recent years, with the recent survey of ASNR members finding that over half of neuroradiologists are currently using intracranial vessel wall in their practices. So let's talk about the main indications to why we use this. So there are a number of reasons to use it, but there are two of the most critical and commonly performed situations. And these have the most amount of evidence as indicated by expert consensus from the recommendations from the ASNR. And the first reason is to differentiate between different etiologies for vessel narrowing. And we're going to talk about this with some cases to illustrate. So first, this is a case of a 44-year-old woman who came in presenting with symptoms referable to her left MCA vascular territory. She came in and she had a negative brain MRR without any evidence of acute infarction, but during her workup, she had a CTA of her head, which found focal severe stenosis of the M1 segment of her left MCA. And since her symptoms were referable to the left MCA territory, she was thought to be having a TIA. This degree of narrowing is very unexpected in someone in their 40s without any real known risk factors. So it was a perfect case to recommend vessel wall MR to further evaluate the etiology behind this area of narrowing. So on her vessel wall MR, she had a focal area of predominantly T2 hyperintense signal. It was positioned somewhat anteriorly within the vessel wall. Just as a comparison, here it is on the sagittal, and this is another view more proximally in the M1 segment. On the post-contrast sequence, we found that she had some avid enhancement associated with this area of eccentric T2 hyperintensity. So putting everything together with this eccentric T2 hyperintensity with the avid enhancement, this was thought to be a culprit atherosclerotic plaque, which was the reason behind her symptoms. So despite her young age and kind of relative lack of any risk factors, we were able to conclude based on the vessel wall MR that she did have intracranial atherosclerosis that was leading to her symptoms, and she went on to be appropriately treated. Here's just another illustrative case of how vessel wall MR can be used in clinical practice. And one of the common reasons we use it is to differentiate from RCVS from vasculitis, which is a common clinical conundrum. So here's another younger woman. She was in her late 40s who presented with some subarachnoid hemorrhage at the vertex. She also had a few small areas of infarction on her brain MR. On her MRA, she had multiple areas of vessel narrowing, including within the bilateral ACA segments. So at this time, the main differential considerations were RCVS and vasculitis. Atherosclerotic disease was considered less likely just given the location and the pattern of narrowing. Specifically, she had more preferential involvement of her distal vessels rather than her proximal vessels. Because of the clinical uncertainty, she went on to get a vessel wall MR, where she was found to have enhancement associated with some of the areas of narrowing in her ACA branches. So this finding of enhancement, as well as the fact that her vessel narrowing persisted on multiple follow-up imaging, was thought to be diagnostic of vasculitis, and she was treated as such. So there are a number of other clinical indications to differentiate between narrowing, including differentiating between Moyamoya syndrome and Moyamoya disease, or identifying radiation-induced narrowing. So really, vessel wall MR can be an incredibly useful tool in patients presenting with vessel wall narrowing of uncertain etiology. In fact, in a study from one of our colleagues here who's on the webinar today, they found that in over 200 patients, stroke and TIA patients, using vessel wall MRI did change the etiologic classification in more than half of patients. So there was a significant decrease in patients who just had intracranial arteriopathy not otherwise specified. They were able to more definitively describe what the etiology was behind the intracranial narrowing. And also they found that the proportion of patients with intracranial atherosclerotic disease also significantly increased. Okay, so I'm going to move on to the next primary reason to perform vessel wall MR, and that's really to identify potential areas of symptomatic but not stenotic disease. And so we're going to use another case to illustrate this example. So here's a 70-year-old gentleman who came in with a left MCA territory infarction. CTA was done at the time of the stroke without any real significant narrowing. It was called normal, and the patient was initially deemed to have a cryptogenic stroke or an embolic stroke of undetermined source because he had no significant narrowing on his vessel imaging and the remainder of his stroke workup was negative. So when we solely use conventional angiographic techniques, we can really only detect plaques, which result in luminal narrowing. And we're unable to visualize the vessel wall. But as we're kind of going to be hearing about today, we're really in this midst of a paradigm shift when it comes to the evaluation of stroke risk. And we know that the degree of luminal stenosis does not equate to stroke risk. So there are many other factors to consider. And a lot of those can be seen on vessel wall imaging. So we're able to assess not only the degree of stenosis, but also characteristics of a plaque, which can really give us more details on the level of risk associated with the plaque for future or recurrent stroke. In fact, a recent systematic review found that more than half of patients who had no significant stenosis on angiographic imaging had identifiable plaque on vessel wall imaging, really highlighting the fact that many patients can harbor plaque with normal CTA and MRA exams. And this really becomes an issue in patients with embolic stroke of undetermined source. So patients are only deemed to have embolic stroke of undetermined source when they've had a full stroke workup. They have no identifiable or less than 50% stenosis in their intracranial and extracranial vessels, and the rest of their workup is negative. The problem is they may not be appropriately treated for a potential source of their stroke, and they end up having a nearly 5% annual stroke recurrent rate. And so it becomes really a target population for us to really be attuned to. And so this is where vessel wall can be extremely helpful. And so this is the patient that we were talking about who had no real significant narrowing on his CTA, and he did go on to get a vessel wall MR. And there you can see he has this eccentric T2 hyperintense plaque with associated enhancement, which was consistent with an active atherosclerotic plaque, thought to be the causative or culprit plaque behind his stroke. So by using vessel wall MR, this patient went from having an embolic stroke of undetermined source to knowing he had active atherosclerosis and was able to begin appropriate treatment. And really this case highlights the important principle that luminal stenosis does not equate to stroke risk. And vessel wall MR has been very helpful in these patients with ESIS or embolic stroke of undetermined source. A recent study found that ESIS patients, so these are all comers for ESIS patients, they were much more likely to have intracranial plaque on the same side of their stroke compared to the contralateral side, indicating that we, again, may be overlooking potential contributors to ischemic stroke. So now we're going to move on to other indications that vessel wall MRI has been shown to be useful. These have been deemed the possibly useful adjunct to conventional imaging by the expert consensus from the ASNR. And the first is to evaluate the activity of atherosclerotic plaque. So just to take a quick second to talk about intracranial atherosclerosis in general, because this really is the most commonly encountered finding on vessel wall imaging. So intracranial atherosclerotic disease is one of the leading contributors to ischemic stroke worldwide. Previously, it was thought to have a kind of a relatively minor contribution to ischemic stroke in non-Asian populations. And a lot of the estimates for the prevalence was in like the 10% or less range. And we think that a lot of this lower prevalence was related to the fact that we were relying on angiographic imaging to evaluate for intracranial atherosclerosis. When using vessel wall MR, the estimated prevalence is much higher in like the 30% range. And actually some autopsy studies are citing a prevalence in the 60% range. So intracranial atherosclerosis is much more common than we kind of think it could be. And just to take a second to talk about what we're imaging when we evaluate the atherosclerotic plaque. So we can see a number of different plaque components, including the lipid core and the intraplaque hemorrhage, which are part of the plaque components itself. We can also detect a fibrous plaque, which is separating the plaque components from the flowing luminal blood. And beyond that, we can see peripheral thin rib of enhancement, usually surrounding the plaque, which can be due to vasovasorum and inactive or culprit plaques. So we're going to talk for a second about what we're looking for when we evaluate for atherosclerotic plaques. It's become very important to determine which plaques are culprit or active plaques versus plaques that just may exist and kind of be more quiescent. And there are a number of imaging tools that we can use to identify these. And so we're going to discuss some of the most frequently cited imaging findings and the evidence behind each one. And we're going to go through this quickly because I know we don't have a ton of time, but first we're going to talk about vessel wall enhancement. So this really is the most commonly encountered and the most commonly discussed imaging marker of atherosclerotic plaque. And it's very strongly associated with culprit or symptomatic plaques, with odds ratios ranging from the 7 to almost 11 range. This enhancement is the definitions vary across studies, but most people say you want enhancement similar to or greater than the pituitary infundibulum, which serves as a very nice control for both of these studies. The problem is this enhancement can last for months after having a stroke. But regardless, this is a very strong indicator of having a symptomatic plaque. Next, we're going to move on to the vessel wall remodeling. So remodeling is a change to the vessel wall in response to plaque formation. So positive remodeling is the outward bulging of the outer surface of the artery as an adaptive response to plaque in order to preserve blood flow. And it really explains why we can see these sizable plaques even without any significant narrowing. Initially, there was mixed data about the risk of positive remodeling, but we have 2 recent meta-analyses which are showing that having outward positive remodeling is more strongly associated with symptomatic plaques, while conversely, negative remodeling is more commonly seen in asymptomatic plaques. There's some data to suggest that negative remodeling, or in other words, a reduction of the outer diameter may be secondary to a more fibrotic or healing response, and these fibrotic plaques may be less likely to rupture, which kind of explains these findings. Okay, next we're going to talk about plaque thickness and wall thickening. And so classically, when we talk about intracranial atherosclerosis, and in many of the examples I've shown today, eccentric wall thickening is true that atherosclerotic plaques are often seen eccentrically within the wall. Some studies have looked to see if the eccentricity of the plaque is actually related to its symptomaticity. And for now, some of the meta-analyses are showing that there's actually no significant association between the eccentricity of the plaque and it being a culprit plaque. And so basically just saying that both concentric and eccentric enhancement of plaques does not make it more or less likely to be a symptomatic plaque. Next, we're going to talk about plaque surface irregularity. And as we touched on earlier, this fibrous cap is kind of this tough fibromuscular layer separating the plaque components from the flowing luminal blood. And anytime there are any kind of irregularities or discontinuities in this plaque surface, there's an increased risk for thrombotic events. So it's really no surprise that meta-analyses have shown that any kind of plaque irregularity is strongly associated with symptomatic plaques. Lastly, we're going to discuss intrinsic T1 hyperintensity or intraplaque hemorrhage. So intraplaque hemorrhage is a very well-established marker of high-risk plaque in the extracranial internal carotid artery, but there's much less consensus when it comes to its risk in the intracranial vessels. There are very few established definitions or guidelines about the presence of this intrinsic T1 hyperintensity with really widely ranging prevalence data. So this is really an area where more data is needed. But there was a meta-analysis which showed a modest association between having intrinsic T1 hyperintensity, we think maybe representing intraplaque hemorrhage, with having an ischemic stroke or a symptomatic plaque. Okay, so moving on from atherosclerosis, we're going to talk about some of the other reasons to use vessel wall imaging in clinical practice. And one is that is cited is to evaluate the activity of vasculitis. So similar to active atherosclerosis, we frequently see enhancement of the vessel wall in active vasculitis. And we in our practice frequently see patients who are followed over time to evaluate the degree of enhancement as kind of a means to assess disease activity. The problem is some studies have shown that the degree of enhancement does not always correlate to disease activity and clinical response. So definitely some caution should be used when using vessel wall. I think it could be used as an adjunct and as another helpful tool in combination with clinical factors for evaluating vasculitis. Next, we're going to talk about aneurysm. So this is an area of great research interest in vessel wall imaging. And we're going to start with where we have the most supportive data. And that is identifying an aneurysm that may have ruptured in a patient with multiple aneurysms. So enhancement in an aneurysm wall is thought to reflect inflammation. And there really is strong data from several studies and meta-analyses that wall enhancement can help identify recently ruptured aneurysms, particularly in patients who have multiple intracranial aneurysms, and we're trying to identify which one is the culprit aneurysm. So in this case, we see with this large aneurysm, which does show some wall enhancement, suggested that it may have recently ruptured. So just some of the data describing some of the strong evidence with a pooled odd ratio of over 34, showing that really having wall enhancement is very strongly associated with a ruptured intracranial aneurysm, even in smaller aneurysms. When we talk about stability, I think this is a little bit more difficult to kind of separate the data, but one of the most interesting findings and important findings is that wall enhancement has a high negative predictive value for stability, basically meaning that not having enhancement around an aneurysm is associated with more stability. And then there are some recent studies which show that enhancement is associated with aneurysm growth. So those enhancements which at baseline, those aneurysms which at baseline demonstrate enhancement are more likely to grow compared to those without enhancement. This is definitely an area where we need more data, and we're continuing to see many studies come in about the prospective ability of vessel wall MR, specifically enhancement, to predict aneurysm rupture. The last thing we're just going to briefly talk about is using vessel wall to identify areas to target for biopsy in cases of CNS vasculitis. And this can just be helpful in order to identify an area where the patient can experience the least amount of morbidity in the setting of a biopsy by neurosurgery. And so it's very helpful for targeting areas where there is vessel wall enhancement to make sure you're getting a really great biopsy that'll provide useful pathologic information. So just in summary, we're going to talk about we went over some of the areas that intracranial vessel wall is most useful. And again, that really is most useful in differentiating between different etiologies of vessel narrowing when we're unsure of what the narrowing could be caused by, and also identifying patients where they could have symptomatic but non-stenotic disease, particularly in patients with embolic stroke of undetermined source or in patients who have normal vessel imaging. There are a number of other indications where vessel wall MR is possibly useful and can be potentially a useful adjunct in addition to other conventional imaging techniques like those we've talked about. That's all I have for today, and I thank you for your attention.
Thank you so much, Hadia, for that wonderful lecture that you just provided us. Our next talk is from Dr. Laura Eisenmunger from the University of Wisconsin, an assistant professor there who's going to be talking to us about clinical interpretation of intracranial vessel wall MRI.
All right, thank you so much for that introduction, and thanks to the first two talks for setting up mine so nicely. And so, as mentioned, I'm going to be talking about clinical interpretation, and so mine's going to be a little bit more case-based. And for the clinical indications, I don't have enough time to go into depth what's causing those, but I'll try to give a little bit of an introduction for our more technical colleagues that are here listening today. All right, the one disclosure I have is that we do work with GE Healthcare, sometimes on vessel wall imaging, but at this point it's related to carotid disease. So the educational objectives are going to be going through a whole host of different clinical indications for vessel wall imaging and showing some of those example cases and how we're using it. And then I'm going to highlight some special considerations. So some, current limitations from a clinical setting, and maybe some of those technical issues that we heard from talk one and how those can affect how we're looking clinically. And this is just a summary of Hedia's prior talk from this position paper from the American Society of Neuroradiology, and we'll work through that with our cases here. And so the first one we're going to focus on is atherosclerotic disease, which applies to these indications. So differentiating among different intracranial arterial narrowing causes, identifying symptomatic non-stenotic disease, and then determining location of atherosclerotic plaque, pretty much. So the one thing I do want to point out, and this is, some of these plaque features are associated with stroke and some aren't, but there's a large variability in reported imaging endpoints. The other big thing is if you start looking at the literature, there's variability in the definition of what a culprit plaque is. And sometimes that includes the T2 weighted imaging. Sometimes that just even has different definitions based on the location of the plaque, whether or not it's the most stenotic plaque, making sure that it's upstream from a stroke event. All of those different things are somewhat variable. And so whenever you're reading something from the literature, please pay close attention to that and see if you agree with how they did it. But because of this, it makes pooling data, interpreting studies difficult. So this is just an example from the literature. And so with atherosclerotic disease, we're looking at those plaques that are more eccentric, meaning that the plaque is thicker on one side than the other, and concentric, meaning more evenly spaced around the vessel. And so this is what we're looking for at that point. This is just another case showing that, where it actually shows that enhancement that goes almost all the way around or all the way around, but it's more thick on one side, so more eccentric. this is going to be an example case of a culprit plaque in a cryptogenic stroke. And so here on the diffusion weighted imaging, we see where this patient has a stroke. And on that side in the MCA, you can see this area of narrowing and apparent vessel wall enhancement present. The one thing that you should consider, though, is that this was a cube sequence. So this was one that did not have additional flow suppression. And there really is a pretty severe area of stenosis right there. And so then there is the question from a technical standpoint, like in talk one, whether or not this is actually enhancing plaque or if it's related to altered flow related to the severe stenosis. And so again, you should really be thinking through what technique you're using and what you're answering. In this case, because of how severe the stenosis is, this is still likely the culprit plaque, whether or not this is true enhancement or pseudo-enhancement. Next case, so right Mca Territory Ischemia. And the question here is this Moyamoya disease? And so as you remember, Moyamoya disease is this disease that happens in younger subjects where they get narrowing and occlusion of proximal vessels. So distal ICA around the circle of Willis, and it means puff of smoke in Japanese. And so that refers to these kind of collateral vessels that happen distal to these areas of stenosis or occlusion. And so the question here on the DSA is this actually Moyamoya disease? This is another DSA image where we can see the severe areas of stenosis. And then even in the posterior circulation, there's some areas of stenosis here. But this wasn't Moyamoya disease. So vessel wall imaging helped us out here quite a lot. So this was atherosclerotic disease mimicking Moyamoya disease, where we see these eccentric plaques that are present again. So not completely concentric, more heterogeneous appearing, which goes along with that atherosclerotic disease that Hedy was talking about. And as she mentioned, it's really important to take into consideration whether or not the lumen is positively remodeled. So there can be narrowing still of the actual lumen, or the lumen can be preserved, but the vessel can actually get bigger, or there can be negative remodeling. And so in this case, it actually looked like the vessel diameter was pretty well preserved, but there was areas of narrowing related to that plaque. And so you can see that in this nice graphic made by one of my students at UW. This is just a little picture of that from the same patient, where you can again see that the vessel diameter is pretty well preserved, but there's areas of narrowing, heterogeneous, irregular plaque there. And so this was atherosclerotic disease and not Moyamoya disease. And this is just looking at that posterior circulation there. Now, I want to show you what actual Moyamoya disease looks like. And so this is a 29-year-old female presenting with a language deficit. And so she has this area of stroke here. And on MRA, we can see these areas where there's severe narrowing present proximally and in the MCA here with some collateral vessels present. So you're starting to get that puff of smoke appearance. What we can see here is that all of these vessels are very, very small in caliber. And so with Moyamoya disease, the studies and vessel wall imaging on this and other studies in general have documented that the vessels actually in Moyamoya disease are decreasing in caliber. And the thought is that the vessel wall is actually not really thickening too. You're losing some of the thickness of the media in that vessel wall. And so they're getting smaller. And also, a lot of the histology is somewhat limited on a lot of these disease processes, but there's thought to be less inflammation associated with actual Moyamoya disease. And so with that, we don't expect a lot of vessel wall enhancement. And so the first study on vessel wall imaging in Moyamoya disease documented no vessel wall enhancement. In this one, you can see that those caliber vessels are very, very small, and there's not a lot of appreciable enhancement there, especially if you're going to compare it to the pituitary infundibulum like Hedy had mentioned. Next case then is this Moyamoya disease again. So we can see that comparison. And so we can see these areas here where the person did have a stroke, and this is a little bit more subacute here. And then there's some areas of more acute stroke as well. On our angiography, you can see again that there's these areas of narrowing present. But on vessel wall imaging, now you can see that there is actually kind of this concentric wall enhancement, which was very different than the other Moyamoya case I was showing you. In addition to that, the actual diameter of the vessel walls aren't as affected here. And so in this case, this was a Moyamoya-like syndrome secondary to a mixed connective tissue disorder. And so Moyamoya disease is going to be in younger subjects, smaller vessels, they're going to shrink down in size with that vessel wall not thickening as much, whereas Moyamoya syndromes are really meaning that you have a Moyamoya pattern on angiography in that areas of like stenosis and narrowing of the proximal vessels, but there's another underlying cause. And so even though it appears that way on like DSA or MRA, you're having a different appearance on vessel wall imaging that can really help you out. And so the initial plan was to do a bypass, which is what you do for Moyamoya disease. But then we saw that there was inflammation, and then you could give steroids, and this person had marked clinical improvement without any further cerebrovascular events. So CNS vasculitis means what it says, inflammation of the intracranial vessel walls. And so you can do conventional angiography where you can find multiple areas of irregularity and stenosis. But on vessel wall imaging, what we're going to be looking for is that homogeneous circumferential concentric enhancement. And that's going to be more homogeneous as a general pattern than atherosclerotic disease, more concentric as a general pattern. But again, in the literature, you're going to see some overlap between those things. So it can help guide you, but there is going to be somewhat of a clinical call as well. And so with that, we have the same indications related to, investigating non-stenotic disease, but then we can also look at that vasculitis activity, as Hediye mentioned, as well as looking for a biopsy source. And so one of the differentiating things here that, again, Hediye touched on, but we should emphasize, is that atherosclerotic plaques often have a hyperintense T2 signal, whereas vasculitic lesions are thought not to. And then you're going to have more of that concentric smooth enhancement. You can also potentially see some enhancement in the perivascular space or in the brain parenchyma too. And so this is an example case of a patient. There's pre-contrast imaging, post-contrast, and then post-treatment imaging, post-contrast, where this patient was given steroids, and then a month later, that vessel wall enhancement that was circumferential and more smooth had resolved. And this is a really, really nice summary slide. Thank you, Mahmood, for sharing this with me, where we have Moyamoya disease, atherosclerotic Moyamoya syndrome. So atherosclerotic disease that's causing a Moyamoya pattern of narrowing, but is not true Moyamoya disease, and vasculitis that's looking like a Moyamoya syndrome as well. And so with the Moyamoya disease, again, smaller vessels, not really seeing vessel wall thickening or enhancement. Atherosclerotic disease, you are seeing that enhancement, more eccentric or eccentric plaque in general, even if it's not enhancing. And then vasculitis, more that concentric smooth enhancement. And this is one of these kind of like outlier cases. I'm going to talk about a couple of these. So focal arteriopathy of childhood is a really important cause of stroke in children. And so you can get an inflammatory type or a dissective type, but the inflammatory type is usually associated with having some sort of illness about a week before, 2 weeks before, is associated with varicella zoster, but also other infectious processes as well. And with that, you're going to have, again, inflammation. So we expect more of that concentric enhancement. And this can be used also to monitor treatment. And so this subject was given steroids, and then that enhancement resolved over time. We could also look at it for the biopsy, as mentioned. So in the ASNR recommendations, they're more referring to biopsy intracranially, but this can also help extracranially. And so there's a vasculitis called giant cell arteritis that involves the arteries mostly of the head and neck. And where you try to biopsy is the temporal artery kind of on the side of your head. And so if we use vessel wall imaging more in a focused area over the temporal region, we can actually identify, potentially diagnose, but we can also help target those biopsies, because a lot of times the biopsies are negative even in people that actually have the process. And so this is just an example case of a 61-year-old female with headache and pain over the temples that was a high concern for giant cell arteritis, and we could identify a spot where it was enhancing and they could go right in and biopsy. All right, 44-year-old female with no significant past medical history presents with a thunderclap headache. In this case, we can see that on the angiography, there's multiple areas of vascular narrowing and kind of smoother vascular narrowing. And this was a case of reversible cerebrovascular constriction syndrome, which is exactly what it says it is. So it is reversible, but your blood vessels essentially constrict down. So those smooth muscle cells are going to shorten, which causes thickening of that vessel wall and narrowing of the vessel lumen. And we need to identify this in contrast to vasculitis, because vasculitis, you're often going to give steroids, whereas for this, you're going to give potentially calcium channel blockers or just wait and see how they're doing. And so in RCVS, it's classically thought to be a non-enhancing process. And with limited histologic studies, it's not associated with inflammation, it's constriction, right? So with that, you're going to get thickening of that vessel wall and narrowing of the vessel lumen, but in theory, not enhancement. However, talking to different people, including our institution, as well as the literature, there do just seem to be some cases where there is enhancement. So there's definitely more study that needs to be done there. And again, we need to really take the whole clinical picture whenever we're looking at vessel wall imaging too, and talk to the clinical team and get the best answer there. Last two things I really want to talk about are going to be aneurysms and AVMs. And so Hediye started to mention, aneurysms in general. And so we can use this potentially to identify ruptured aneurysms in patients. And so that's pretty decently supported in the literature. And then predicting future behavior is something that there's a lot of studies still ongoing about. Again, some of the limitations with those studies is that there's a large variability in the pulse sequences that are used, and we have very complex flow going on within aneurysms, as well as the definition of instability of aneurysms in and of themselves is very different. And so that can be enlarging, that can be symptomatic. We need to be really careful when looking at the literature, what each study is doing. We also need to be really careful what they're using as a definition of enhancement, whether or not that's like adjacent normal vessel wall, whether or not it is that pituitary infundibulum, those things will affect the studies. The other thing is morphology. So sometimes it's just the studies are presence or absence of enhancement. Sometimes they're talking about eccentric, concentric again, sometimes ring-like. It really, really depends on what they're doing or percentage of the wall that's enhancing. So when we're doing the pooled studies again, we just have to be really careful how we do that and how we're doing these investigations and try to discuss as a society how to best do those, as well as the different MRI sequences that are used. So this is an example case of a ruptured pica aneurysm. So we see all this subarachnoid blood, and there's actually two pica aneurysms. And so one of them is enhancing, as we can see here, and one is not. And so this actually helped guide treatment, where they did a craniotomy only on that side and treated the one that was actually ruptured, which they confirmed surgically. The other thing is we do have to consider those stable aneurysms that are enhancing. And there are a couple studies out in the literature now documenting that there are a number of aneurysms that are stable while enhancing, and that potentially makes sense. Some things could enhance because of actual inflammation and inflammatory cells. Some things could enhance because there's fibrosis. And so a lot more studies need to be done in this area. And then the other big thing is that pseudoenhancement that was talked about in the first talk of this webinar, which is, if we're not getting complete blood flow suppression, especially if there's complex or slow flow, that's another really big issue. And so we need to take that into account in those studies. And as a radiologist, we need to be aware of what type of sequences and what resolution our institution is using, and how susceptible those sequences are to having flow-related enhancement and issues whenever there's complex flow. And so this is an example case that Sheng was nice enough to share, and he showed this also at SMRA. And so you can see that, there's this incomplete suppression of blood flow centrally, and the more incomplete suppression there is centrally, the more that we have to assume there's going to be around the periphery as well. And you can see as we add in, additional flow suppression, a lot of that vessel wall enhancement actually goes away. But some of it does persist, like this area here, where, you can see that there is potentially still some enhancement in some areas of this aneurysm. And these are two examples with very big aneurysms. A lot of times we're going to have smaller aneurysms where we're not going to get this beautiful picture. And so in the clinical setting, it's a little bit more complicated in and of itself. And then the last thing I want to talk about is arterial venous malformations. This is kind of a new area where there's a couple of case series out in the literature now and some discussion about whether or not this could be used to identify areas of rupture or AVMs that are more at risk. I guess I just want to caution that if there's complex flow in aneurysms, guess how complex the flow is going to be in this tangle of vessels. And so really using those flow suppression techniques are going to be really, really important here. And also, really taking this with a grain of salt in a discussion with our clinical team and pairing it with other sequences such as susceptibility weighted imaging and seeing if the enhancement is correlating to the area where the rupture occurred. And this is just another example to show that, you actually can get enhancement in these AVMs that are outside the vessel wall and in the brain. And, there was some speculation as to whether or not this could be related to inflammation, but I also want to caution that AVMs can have abnormal brain tissue in between the vessels. And so it could be related to more gliosis related to the brain. And this is my last case, just with an AVM that didn't have hardly any vessel wall enhancement, but this small area, which happened to be the biggest vessel in that nidus. And so we were pretty pretty convinced that that was just related to flow alterations. And so thank you for listening to my whirlwind of a clinical talk. And as I mentioned, a lot of this is still up for discussion. And I tried to show some example cases to give some differential as to what we're looking at as radiologists, but the literature is still evolving, and hopefully we'll have a good discussion after the last talk. Thank you.
Thank you, Laura, for the excellent case review. So now we move on to the last talk for today. It's Dr. Niranjan Balu from University of Washington on future horizons. You need to unmute yourself, Niranjan.
Yeah, thank you very much. Hello, everyone. I'm asked to talk about the future horizons of vessel wall MRI. Not having a crystal ball with me, I can definitely share with you what the field is doing currently and where it seems to be heading in the next 10 to 15 minutes. So as we heard in the previous talks, 3D high resolution imaging is necessary along with good flow suppression and blood suppression in vessel wall imaging in the intracranial arteries. But to take a little bit of take this a little bit more towards the higher resolution, what we can see in this simulation study nicely done by Antigua, we can see, although it was based on coronary and carotid arteries, since it's a simulation study, it's equally applicable to the intracranial arteries. Here we can see, for example, if we take a 0.7 millimeter isotropic resolution, then the true wall thickness we can actually measure is almost double of that, around 1.4. Similarly, for a 0.5, we would be able to measure true wall thicknesses of around 1 millimeter. Knowing that the normal wall thickness based on histology studies is around 0.2 to 0.3 millimeters, you can see that we need much higher resolutions, around 0.1, 0.2 even, if you want to look at normal vessel wall thickness. And with the thickened vessel wall, we can do even higher, maybe 0.3, 0.4 millimeter isotropic. The current clinical standard is around 0.5 millimeter isotropic. So there is still a way to go in terms of achieving good resolution for vessel wall imaging. The second thing, as noted in the previous talks, Bhagya referred to this, VISTA sequence by itself has inherent blood suppression capabilities, but it doesn't suppress CSF inherently by itself. So in order to do the CSF suppression, we introduced Dante because it has this nice characteristic of jointly suppressing both blood and CSF, CSF being more slow flowing than blood in this case. And here you can see, compared to the regular VISTA, the Dante VISTA suppresses the CSF much more. The other thing to note is that although clinically the physicians tend to use only the T1 space imaging, multi-contrast vessel wall MR may be really required for differentiating these vessel wall pathologies. This was alluded to by the earlier speakers who noted some T2 weighted imaging may be useful. In this talk by in this work by Moshe Basha et al, they clearly showed that T2 can differentiate between ICAD and non-ICAD lesions. And beyond that, if we add T1, then we can identify even further ICAD by eccentric wall thickenings. And after this, the contrast enhancement comes into play, where we can differentiate vasculitis from RCVS between its enhancement and non-enhancement characteristics. So the thing to note is we need a multi-contrast vessel wall MRI for the future applications. So towards this effect, we introduced this accelerated multi-contrast vessel wall MRI protocols, which included T1, PD, highly T1 weighted weighting called SNAP to look at hemorrhage or blood products, and an angiographic top sequence. Even with going with a 5-minute per scan of acceleration using a particular acceleration method we developed called custom step, this would require about 30 minutes for the whole exam including patient positioning. So, so as we can see, if we had to go to even higher resolution, multi-contrast imaging, some kind of acceleration is needed. So compressed sensing has been found to be also effective in this, and this can also be applied instead of this custom step acceleration in the future. So the other topic to be aware of from the imaging side is the need for CSF suppression. CSF suppression is very important for intracranial imaging compared to other vascular beds, of course. But the thing to note is that Dante alone may not be sufficient for good or uniform flow suppression in the CSF. It can fail if there is some hyperdynamic CSF or some field inhomogeneity. For example, here Dante space alone doesn't provide good CSF suppression, but in combining with the anti-drive or the inversion mechanisms, the combination of these techniques may be able to provide better flow CSF suppression here, as you can see here. And compared to T1 imaging, T2 weighted imaging, CSF suppression is inherently more problematic. And often the CSF cannot be suppressed in T2 weighted imaging just by using Dante and T2 weighted space imaging. For example, here we can see that there is unsuppressed CSF flow. But this new publication advocates the use of T2IR combined with space imaging to acquire very well suppressed T2IR, T2 weighted space imaging. So this kind of combined techniques may be important for getting this multi-contrast vessel wall imaging to the applications. But one thing we have to be aware of is that combining these sequences will give some kind of a mixed weighting, not really T1 or T2 weighted space imaging. So the effect of this particular combinations and how they play on evaluating different pathologies has to be evaluated in the future. So once we did all this imaging, we get a big stack of high resolution 3D images with hundreds of images. So the next step is to interpret it. In the clinical domain, looking at a few images may not be so difficult, but if we look at multi-contrast images together, then it will become more challenging. So some of these newer methods have been focusing on how to evaluate this. So one particular group by or work by Nan Zhang looked at getting cross-sectional images at particular locations, for example, here the basilar artery, the vertebral artery, and then looking at measuring them. But this will not, this will be a problem if we look at several different contrast weightings, as it will greatly increase the manual work needed for the reviewers. So what we have developed here is a multiplanar, multi-contrast, and also potentially able to review multiple time points called the Moca reconstruction and evaluation tool. How this functions is we use all the different contrast weightings that can be acquired, for example, PD, T1, T2, and time of flight, and they are all automatically registered. And then there is an automatic step of identifying the center lines and also the labeling of the different arteries. So once these are labeled, we can pick out particular vessels to further look at. For example, we may want to look at the MCA. And if we choose the MCA, then we can bring up this multi-contrast MPR locations, and each of these can be reviewed efficiently. So what it comes down to is it becomes a pipeline which can be automatically processed. The different steps are, first is the registration among these different contrast weightings, and then there is vascular tree mapping, which can be done on an angiographic sequence, in this case the time of flight. And since this is registered to all the other sequences, then we can do this center line based reformation to get these cross-sectional sections. And then that can be directly presented to the reviewers for doing the lesion segmentation identification, and also getting quantitative metrics if you need to be. So this is the how this can be done. This essentially shows the arterial center lines evaluated on the time of flight. These are automatically derived. And then we have chosen this particular segment to be evaluated. And then this is the straightened artery view on this time of flight, and this corresponding black blood sequences that are registered. So we can see that T1, PD, and the post-contrast T1, and the cross-sectional corresponding images. So the reviewer can move along this straight line or a straightened artery and evaluate at different locations cross-sectionally. And this can be done not only on one time point, it can be done on multiple time points simultaneously if they need to be. So we can compare treatment responses, for example. So this is a case where we have a plaque in the artery, and this is using this multi-contrast MRI with 4 different contrast weightings. And here we can see the cross-sectional images that are automatically displayed. In this case, fairly non-stenotic, but there is a plaque that is identified here on the T1 and the PD and the post-contrast T1. And this can also be done in combination with other modalities such as a CT angiogram. In this case, for example, we can see a lot of calcification on the CTA. And in this case, this is denotes a calcification in this location, but it's fairly not visible on the pre and the post-contrast T1 vista. Just showing that how combining a multimodality information using this Moca view can be useful. So it can be used, Moca can be used for more research studies also, where we are looking at actual measurements instead of just interpretations. So we used the Moca in this study to do actual segmentations of the vessel wall and do measurements of the maximum wall thickness and the total vessel area. And we can see in this group of subjects, for example, the highest wall thickness is in the supraclinoid ICA, and in general, the ICA compared to the other locations of the intracranial arterial tree. So I want to emphasize that in this previous study, the segmentations were still done manually. So even though the Moca pipeline facilitates the previous setup for the reviewer still has to go in and draw these contours, which may be a problem if we didn't focus on a few locations, but we wanted the entire arterial tree to be segmented. And this is where the AI-based automatic vessel segmentations can play a role and help greatly. So there are several, not several, but a few papers that have started to do this. In this work, they used a unit-based AI algorithm to segment a single contrast weighting of T1 vista. Here is the original image and the pre-processing to do some contrast equalization, and then the unit is applied to get the lumen and the outer wall. Here we can see the artery and the corresponding lumen and the outer wall identified. One thing to note here is that this can be done across the entire length of the artery, and then several locations can be identified for the reviewer or the physician to radiologist to look at, and these are these locations. One thing to note also here is that in this location, for example, a reviewer would draw more smoother contours here, where there is still some improvement to be done here. So that has been kind of the motivation for this vessel wall imaging segnet, which is based on a unit but has some residual connections to help with increase for the network to focus on more detailed in the vessel wall and also and the contours. So here we can see, for example, not only are they able to do intracranial vessel wall segmentation, but even though the network is only trained on the intracranial arteries, they were also able to do some segmentation on the extracranial carotids. And the VW segnet seems to get more smoother contours in these particular cases compared to the manual. And the difference between the automatic and the manual segmentation was also very small. So one of the limitations, as we noted here, this is for only demonstrated for single contrast weightings. So with a multi-contrast acquisition, the segmentation may be slightly different and we can get other information. So in future, I think the AI segmentation of multi-contrast intracranial vessel wall will become important. And also as shown by this previous study, the segmentation dice coefficient, which is basically the accuracy of segmentation, is higher for larger arteries and tends to fall for smaller arteries. So this is also something that can be addressed from a neural network point of view, or as we saw from an imaging point of view by developing higher resolution sequences. So finally, I would like to touch on this issue of contrast enhancement. As we saw in previous talk, contrast enhancement plays a very outsized role in intracranial vessel wall imaging for looking at many different pathologies and also intracranial aneurysms. And one thing, I'm moving beyond just identifying yes or no of the contrast enhancement in order to say, for example, look at whether how the subject has improved or the lesion has improved with treatment. We will need to do quantitative measurements of this contrast enhancement. So and in that case, the normalization tissue becomes very important. And as Hidia noted, usually the pituitary stalk is traditionally used as the reference for contrast enhancement. And it is not clear that this is the right or the best reference tissue. So if we wanted to look at what is the best normalization tissue, looking at three different tissues: the genu of the corpus callosum, the pituitary stalk, and the white matter. And if using any of these different reference tissues, once we have the segmentations of the arteries, we can start to look at the quantitative measurements of the tissue within. For example, here is a contrast enhancement, and we can display it or provide it as a quantitative contrast enhancement map. So we can see that this location is at least 50% more enhanced than this tissue, for example. So in comparing the different reference issues here, we see that the genu of the corpus callosum turns out to be the most reproducible in terms of contrast enhancement. So the pituitary stalk may not be the best reference issue for quantification. So in summary, so we touched on three different aspects: imaging, interpretation, and also quantification. In imaging, I think high resolution 3D isotropic imaging with multi-contrast and better CSF suppression techniques will be coming ahead. And in terms of vessel analysis and interpretation, again, Moca views are enabling multiplanar, multi-contrast, and also multimodality with AI-assisted identification and segmentation will be very helpful for radiologists in the future. And also quantification, including vessel wall metrics and contrast enhancement, I think are future needs. So with that, I'd like to acknowledge my lab members and the SMRA for this opportunity.
Okay, thanks, Narendra. Now we have about 15 minutes we can people can ask in the Q&A part to so we can pick up the question and see any panelists can answer.
So I can maybe start off by asking a question I have. And we could go down the line in terms of panelists. In your clinical practice, what is the approach? What is the ordering approach from, say, neurosurgery in terms of vessel wall imaging and aneurysms? Is it something your group does? Is it something you do in terms of aneurysm treatment decision-making? Do they do it in problematic cases? Is it something you do post-treatment? How does vessel wall imaging fit into aneurysm assessment at your practice?
I can start. So we use it quite a bit actually in aneurysm, both treatment decision-making as an adjunct to the other kind of conventional angiographic techniques. So if there is no enhancement, I think it confers a little bit of more security on neurosurgeon's part to not go after it. And we also do vessel wall imaging for post-treatment, like post-coiling patients, just to look for residual filling or anything like that. So we use it quite a bit.
There's a question from Giles.
We can just give the other panelists a chance to answer as well.
Sure.
Yeah, at University of Wisconsin, we use it a little bit less. There's a little bit more emphasis on shortening our aneurysms studies right now. And so we do more just like MRA and then T2 imaging, and we use it more for like problem solving related to like whether or not to treat something or stability. But that being said, like I was at Utah for a while, and then UCSF, where I was at prior to UW, uses it a lot for everything, including monitoring and whatnot. So I think, yeah, it kind of so much depends where you're at.
Yeah, it's kind of very similar in MRAs, like Wisconsin. We are not using a lot of these in the aneurysm follow-up. It's probably mostly like a problem solving, but we are planning to use this routinely in all our patients. That's kind of in the pipeline, but at present, it's mostly for vasculopathies and other things, not so much for the aneurysms in MRA.
And I can speak to University of Washington and how we approached the utilization of vessel wall imaging and aneurysms. Occasionally, we would get vessel wall MRs for problem solving, cases where they didn't see an aneurysm and they were concerned for a possible aneurysm, to see if vessel wall MR would indicate something, or an unclear lesion. You know, could this be a ruptured aneurysm, or is it just kind of, you know, an infundibulum or something else? That would come up occasionally, but generally in most aneurysms, we did not perform vessel wall MR. We did do it in post-treatment of aneurysms, specifically from one of our vascular neurosurgery providers, to assess for the potential for the presence of inflammation and the potential of development of angiographic vasospasm. So that was one area that we did apply it. But generally, yeah, not used frequently in the setting of aneurysm assessment.
Okay, so I will bring up the question from Giles Raditi on what, in your opinion, are the best commercial sequences for intracranial vessel wall imaging for those of us who do not have Dante or etc.
Yeah, I can take that question first. Yeah, if there is no Dante, even the regular TSE sequences would be the first option. That's like the Vista and the Philips or the Cube or Space and the other platforms. Without Dante, we can use, for example, MSDE for blood suppression. If that is not available, then some kind of inversion recovery combined with the Vista, the anti-dive pulse, for example, those are also other options. You know, if none of the other options are available, then just the straight VISTA type sequences should be enough for most of the applications.
I have a question for Bahaya. So for the Dante prepared space, so it's supposed to suppress the CSF very nicely, but still Dante do you in your practice, do you see that there's still some very slow flow associated with CSF on certain areas that still be a problem or not?
So yes, Dante overall does a great job, but yes, when the flow is kind of very slow, mostly in the region like where the MCA bifurcates, where there are kind of small pockets where the velocity of the CSF is very low, we do have, but most of the time you can kind of recognize these are mostly artifactual, but compared to the space overall, it is definitely helpful. That's what is my experience.
Any other questions from the audience?
Does anyone still use 2D vessel wall imaging, or do you use it in conjunction with 3D imaging? Or has everyone completely ditched 2D applications?
Yeah, for intracranial imaging, I can only speak from the research side, and sometimes to the clinical side. So here, I think we only use 3D imaging for intracranial because that's much easier to look at many different reformats and identify all the different plaque components that can occur. That would be much more difficult with 2D imaging.
Yeah, we're only using 3D as well.
In Emory, there is one scanner, which is kind of the older version, and it's one of the inpatient location where we do not have much option. So if the patient is scanned in one of those locations, we are using 2D. Otherwise, it's everywhere, it's 3D. It's just the limitation because we don't have an upgraded scanner.
Yeah, we use 3D only as well.
I have another question here. So you always acquire both pre-contrast and post-contrast images. What do you see? What information do you get from the pre-contrast?
So I can take a first stab at this question. So the post-contrast comparison is required to the pre-contrast so that we can identify enhancement occurs or not. Instead of just being like unsuppressed flow, for example, right? So that's one reason to have this pre-comparison and post-contrast comparison. But in some cases, if there is like very little time to run a pre-contrast, then I think I've seen some investigators just run post-contrast sequence and just go with it for clinical interpretations. I'd like to get other people's opinions on the clinical aspect of it, whether you really do need a pre-contrast compared to post-contrast.
Yeah, I can comment. So we have added on like a vessel wall imaging sequence clinically after seeing some of the exam and having a kind of an MD check part of the way through, and you can still answer a lot of questions even if you didn't have the pre. And actually, whenever I was at UCSF as a fellow, we did actually look at about 150 scans of vessel wall imaging to see if we found anything on pre-contrast imaging. And I think there was only one exam that it may or may not have changed what we said in the final. But the big thing is honestly that like Hedia's lecture where she introduced, whether or not T1 hyperintensity, intrinsic T1 hyperintensity is a factor related to stroke or other things going on, it's relevant. Also, if there's like thrombus in an aneurysm, it could be relevant. And the other maybe biggest thing is that radiologists are really uncomfortable calling enhancement without confirming that there isn't intrinsic T1 hyperintensity. So a lot of times you could probably read through it, like you could use other sequences and get the same answer 99 or 8 or 7% of the time. But it's part of it's a discomfort too.
And in terms of applications, how many of you are using T2 weighted vessel wall imaging?
Yeah, we use T2 in conjunction with our Dante's pre and post on every case. I think it's really helpful, as Laura mentioned, it's really helpful for kind of the differentiation between athro and other things. And so we always use T2.
Yeah, T2 weighted would be very helpful. I think the caveat is to get good CSF suppression there.
We honestly use it a little bit less. So like every once in a while we will, but it's not like a standard thing that we always add.
We're not using that as much as kind of in Europe or other places. It's very less the way we use T2. It's mainly because of the time constraint.
So just clarify, the T2 weighted contrast is before contrast or post contrast?
It's before contrast.
You have a separate T2 weighted sequence before contrast, in addition to the T1 space, right?
Yeah, it's a T2 space, yes.
Well, I think we're a little over time. Thank you so much to all the panelists for providing such exceptional talks and for really educating us as an audience on intracranial vessel wall MR. And thank you for all the attendees for coming and listening. We really appreciate your time and hope you have a wonderful weekend. Thank you so much.
Thank you,
Thank you.
everyone.